When you picture emergency medical services, maybe you think ambulance, stretcher, getting to the hospital fast. But for an EMT, arriving at, say, a bad car crash or a building collapse, well, your world suddenly gets a lot bigger than just patient care.
That's really the core of what we're digging into today. We're looking at rescue, extrication, what an EMT really needs to know to work effectively within that larger rescue team. Because, the patient is always the focus, but the absolute first priority has to be safety. Yours, your team's. The scene's not safe, you can't help anyone.
Right. And we use terms like extrication, basically, getting someone out of a trapped situation, disentangling them. Most of our listeners are familiar with the basics, but it's key for the EMT to grasp how these things play out in really complex spots, like a wilderness rescue or a tangled vehicle wreck. It's about knowing what you can do and, just as importantly, what you can't.
Exactly. We're usually there supporting specialized rescue crews, but you have to understand the process, the language they use.
Okay, let's start at the beginning. Scene safety. It's more than just throwing on a safety vest, isn't it? It's about your mindset, having the right gear when you step out of the ambulance and into potentially, well, a hostile environment.
Yeah, the gear depends entirely on the hazards you spot during that initial size up. Could it be full turnout gear, might need a helmet, hearing protection, but there's one detail that often gets missed, something the sources really stress. Double gloving during extrication.
Double gloving. We already wear medical gloves, the fluid-proof ones. Why the extra layer?
Because those nitrile or latex gloves offer zero protection against physical injury. Think sharp metal, broken glass, maybe ropes, hydraulic tools. You need a real barrier.
Yeah.
So the rule is heavy leather gloves over your standard medical gloves.
Oh, okay.
The leather protects from cuts, scrapes, even heat, while the inner glove keeps that BSI, the body substance isolation, intact. It's just non-negotiable in that setting.
That makes sense. A small detail that reflects a harsh reality. Okay, let's shift to modern vehicles. They're built safer for occupants, but those safety features can become real hazards for us responders after a crash.
Absolutely. Take airbags or supplemental restraint systems, SRS. It's often not the ones that deployed that are the issue. It's the ones that didn't. They can still have stored energy, damaged sensors. They can inflate unexpectedly while you're working inside.
Okay, so imagine I'm trying to manage a patient's airway. They're trapped, and there's an undeployed passenger airbag right there. How do you practically maintain that safety buffer zone you need?
That's where training hits reality hard. The guidelines are pretty clear. 5 inches clearance for side impact bags, 10 inches for the driver's side, and a full 20 inches for the passenger side airbag.
20 inches.
Yeah, 20 inches. That means you physically can't be kneeling right in front of that passenger working on them if that bag is live.
Yeah.
You have to approach from an angle or sometimes wait until the rescue team confirms the system is fully disabled. It's something you're constantly thinking about.
And what about things like shock-absorbing bumpers? They look pretty harmless.
After a crash, anything but. They often use hydraulics or pneumatics, and they can get compressed loaded in the impact. If they suddenly release, they spring back with enough force to cause serious leg or knee injuries.
Wow.
So the rule is simple. Always approach from the side. Never stand directly in front of or behind the vehicle after a collision.
We also see that sort of dusty haze sometimes after an airbag goes off. Is that stuff dangerous?
Generally, no. It's usually a mix of a harmless gas and something like cornstarch or talcum powder. Manufacturers use it to help the bag deploy smoothly, reduce friction burns. But while it's not toxic, it can cause problems. Well, I've seen patients panic thinking it's smoke from a fire.
Yeah.
And for someone with asthma or another respiratory issue, it can definitely trigger breathing problems. It just adds another layer to managing the scene and the patient's anxiety.
Okay, so we've touched on vehicle-specific hazards. Let's look at the bigger picture, the framework for managing these complex scenes, the 10 phases of extrication. Having a structure like this helps keep chaos under control, right?
It's absolutely the operational backbone, and the EMT's role starts right at phase 1, preparation. That's not just about initial training, it's daily checks. Making sure your ambulance is stocked, extrication tools you might carry are ready, preventing failures when things get real.
Then comes arrival and scene size up. If we're the first ambulance there, what's the most critical first move with positioning the vehicle?
You need to use that ambulance as a barrier. Position it to block oncoming traffic, create a safe working zone behind it. Another thing, try to limit your warning lights. Just use what's essential. Too many flashing lights can distract or confuse other drivers.
That's a good point.
And here's a little pro tip. If possible, park so the back of your ambulance faces the scene. It seems small, but it speeds things up significantly when it's time to load the patient for transport. Avoid parking right alongside the wreck if you can help it, especially on an active road.
What if there are hazardous materials involved? Spilled fuel, chemicals?
Standard procedure,
Yeah.
park uphill and upwind. Always. Fumes, liquids. They'll follow gravity and wind. You want distance and elevation.
And the core of Size Up is that 360-degree walk around. We're looking for hazards, obviously, but also clues about injuries, the mechanism of injury, the MOI.
That's right. You're looking for things like a bent steering wheel, maybe imprints on the dashboard where knees hit. Those clues tell you a lot about potential internal injuries. A knee hitting the dash. That force can travel right up the femur, potentially fracturing the hip. So you assess the MOI, count the patients, look for downed power lines, leaks, fire risk, the whole picture.
Which leads us nicely into hazard control and stabilization. Okay. Let's say we find power lines down, maybe touching the car. What's the protocol?
You do nothing. Absolutely nothing with the lines themselves. You never, ever try to move them. The patients stay in the vehicle until the power company arrives, confirms the power's off, and declares the lines safe. Your role becomes scene security, keeping everyone back.
Okay, power lines secured. We can approach the vehicle. What's the stabilization checklist?
Simple stuff first. Put the vehicle in park, set the parking brake, turn off the ignition, then the battery.
Right, disconnecting the battery cables.
Both cables need to be disconnected, and it's usually negative first, then positive. This minimizes the chance of sparks igniting fuel vapors or leaking fluids. But this gets tricky with newer vehicles.
You mean alternative fuel vehicles, hybrids, EVs?
Exactly. They add complexity. The high-voltage batteries aren't always under the hood. They might be in the trunk, under seats. And disconnecting the standard 12-volt battery doesn't necessarily de-energize the high-voltage system immediately.
How do we identify those risks?
Look for thick cables, usually covered in bright orange sheathing. That's the universal sign for high-voltage components. Be aware that these systems can hold a charge for up to 10 minutes after everything seems off. And critically, if you smell anything unusual like a harsh chemical odor or your eyes or throat start to burn, get out immediately. That could be toxic fumes from a damaged battery. Safety first, always.
Okay, scene stabilized, hazards controlled. Let's move into the middle phases, gaining access, emergency care, and removal. How do we actually get to the patient?
We always start with simple access. Think, try before you pry. Can you just open an unlocked door, roll down a window, check every door handle first? Only if simple access doesn't work and the patient's condition is urgent do we consider complex access.
And complex access usually means specialized tools, right? Like the hydraulic cutters and spreaders, the jaws of life. That's typically the fire department or rescue squad's job. What about tools an EMT might use?
An EMT should generally only use basic hand tools they might carry on the ambulance, maybe a pry bar, window punch, perhaps a hacksaw in a dire situation. And really, only if waiting for the rescue crew creates an immediate life threat. Otherwise, our job is patient care and communication, while the specialists handle the heavy cutting and prying.
So let's say access is made. The scene around the patient is safe enough to work. Now the EMT's focus shifts hard to medical care, even while the patient is still trapped. What's the absolute first priority?
This is where protocols can differ slightly from a non-trapped patient. Assuming there isn't an immediate environmental threat like fire forcing removal, you do your primary assessment before more extrication happens. And the very first clinical priority is stopping exsanguinating hemorrhage, massive life-threatening bleeding.
So controlling severe bleeding comes even before things like C-spine control or airway management.
In this specific context, yes. If someone is bleeding out, nothing else matters until you control that hemorrhage, usually with direct pressure or a tourniquet, if appropriate. Once major bleeding is controlled, then you immediately move to manual C-spine stabilization, opening the airway, giving high-flow oxygen, assisting breathing if needed, managing other bleeding, and treating critical injuries. Bleeding control first. That's key.
And while the rescue team is potentially cutting the car apart around the patient, how do we keep the patient safe from that?
You have to shield them. Use a heavy, fire-resistant blanket or even a backboard slid between them and the cutting operation. Protect them from flying glass, sharp metal shards, sparks, the noise, the vibration. Hearing protection for the patient, if possible, and definitely for yourself is important too. It's a constant process of shielding and treating simultaneously.
Okay, then comes removal and transfer. This sounds like a real team effort with the rescue crew, figuring out the best way to get the patient out.
It absolutely is. You're deciding together. Does the patient come out the door? Does the roof need to come off? It depends on their injuries, how they're trapped. But sometimes, if the patient isn't physically pinned but is critically ill, maybe need CPR, or the car's about to catch fire, we use what's called the rapid extrication technique.
How does that work?
It's designed for speed, getting the patient out in usually under a minute onto a long spine board while doing your best to minimize neck and spine movement. It's not ideal spinal care, but it's used when the immediate threat outweighs the potential spinal injury risk. But even after removal, we need to think about delayed problems.
Like crush syndrome. You mentioned that risk with prolonged entrapment.
Exactly. When limbs are compressed for a long time, muscle tissue starts to break down, releasing toxins like potassium and myoglobin. When you suddenly free the limb, releasing that pressure, all those toxins flood the bloodstream. It can cause kidney failure, dangerous heart rhythms, severe metabolic problems.
So the EMT needs to anticipate that.
Yes, absolutely. You need to recognize the potential for it based on how long they were trapped and communicate that risk clearly to the receiving hospital. They need specialized treatment, often involving lots of IV fluids and medications before the pressure is even released, if possible.
Let's change gears a bit. What about those highly specialized rescues? Situations where the ambulance can't just drive up cave rescues, trench collapses, maybe a structural collapse after an earthquake.
Right, these are technical rescue incidents, and the key thing for the standard EMT is your role is usually very limited unless you have specific technical rescue training yourself. You typically stage nearby, set up a treatment area, and wait for the specialized teams to bring the patient to you.
Why is it so important not to jump in?
Because you can easily become part of the problem. These environments are incredibly dangerous. You could trigger a secondary collapse, get injured yourself, interfere with the rescuer's technical systems. Your job is medical support outside the immediate hazard zone.
Can you give an example, like a trench collapse? What are the specific dangers there?
Trench rescue is notoriously hazardous. The biggest risk is secondary collapse, the walls falling in further. The main cause, vibration. That's why all vehicles, including ambulances and fire trucks, need to park at least 500 feet away. Engines off.
500 feet.
Minimum. And you never, ever enter a trench that's deeper than 4 feet unless it's been properly shored up by the rescue team. The weight of collapsed soil is immense. Survival rates are low.
Okay, what about tactical situations? SWAT callouts, active shooter events. Sometimes we hear about tactical EMS or TEMS.
Right. In those scenarios, standard EMS stages in a safe area, usually directed by law enforcement, until the scene is declared secure. If a specialized TENS unit is on scene, they might operate under different guidelines.
Different how?
Because of the active threat, they might have protocols that seem to contradict standard EMS practice. For example, under direct fire, they might prioritize getting a wounded officer or civilian out of the line of fire immediately, possibly even before applying a tourniquet or doing full C-spine precautions. It's about balancing immediate life threat from violence versus other medical priorities. It's a very specific, high-risk environment. Regular EMTs need to understand why TEMS might operate differently.
And in all these multi-agency complex incidents, who's coordinating everything?
That's the role of the incident commander, the IC. There should be one person clearly in charge, coordinating fire, EMS, rescue, law enforcement. Everyone reports through a chain of command under the IC. A lack of clear incident command is often a recipe for confusion and danger.
It makes sense. And looking back at rescues that didn't go well, there's that mnemonic failure that sums up common pitfalls.
Yeah, it's a useful reminder. It stands for failure to understand the environment, additional medical problems not considered, inadequate rescue skills, lack of teamwork, underestimating logistics, rescue versus recovery mode, not considered meaning. Is this still a rescue or has it become a body recovery? And equipment not mastered. It highlights that failures are often systemic, not just one small mistake.
This whole discussion really underscores the intense, constantly shifting responsibility of an EMT in these situations. You're managing your own safety, dealing with a dangerous environment, cars that can hurt you, and trying to provide critical medical care under pressure.
It really demands constant situational awareness. The scene changes second by second. And that communication link, the EMT telling the rescue leader about the patient's condition, the rescue leader updating the EMT on the extrication plan, that back and forth is absolutely vital for a safe outcome for the patient and for the responders.
It's a fascinating blend of technical skill and medical knowledge under extreme stress.
So thinking about those 10 phases of extrication we discussed, here's something for you, our listeners, to consider. Where does that tension between moving fast, because your patient is critical, and following every single safety step meticulously pose the biggest challenge ethically and practically for responders on scene?
Yeah, that judgment call. Knowing when speed is essential versus when patients for safety is paramount.
Yeah.
Mastering that risk assessment is really at the heart of effective emergency response in these complex situations.
Thanks for joining us as we explored the EMT's role in extrication and rescue. We hope this gives you a richer appreciation for the complexities involved and maybe sparks some interest in looking further into incident command systems or the physics of trauma.